Hi, I'm Brian Vines, and welcome to the ZerMed Show. On the show, we will feature local community physicians who are experts in their respective field and who will share their experiences and wisdom. We'll cover a broad range of health topics on the show, and today we'll be discussing breast cancer. And I have the honor of welcoming Dr. Simone Mays, who is a breast surgical oncologist here. Doctor, welcome to the show.
Thank you, Brian. Thank you for the opportunity to be here with you today.
We really appreciate you taking time out of what I imagine is a super packed schedule. But in the service of that, I wonder, is there a typical day for you in the life of a surgical oncologist here?
Yeah, absolutely. So, the majority of my days I spend seeing patients in the office, and then I have dedicated days where I do surgical procedures. So, for instance, for a day that I'm seeing patients, I come in the morning. I usually will review patients' charts before they come, review the schedule, have a sense of why patients are coming. Oftentimes patients, particularly with breast cancer patients, they've had prior imaging and biopsies and those sort of things. So I review all those so I can kind of organize how I want the consultation to go. And then I see patients throughout the day. And then typically go home in the afternoon, be home for dinner with the children.
Yeah.
Operative days, I tell patients all the time, the OR never runs on time. So don't get fixated. My surgery is scheduled for 10 o'clock because things happen. Yeah. So I have a dedicated day where I do that. Yeah.
So looking at a community of care that surrounds patients who are going through their cancer treatments, many of us may be familiar or think we have an idea what an oncologist does.
Right.
But can you tell me what your particular field of specialization, how that fits into a community of care for a breast cancer patient?
Right. So as a breast surgical oncologist, my primary responsibility is the surgical management of breast cancer. I often see patients that don't have breast cancer who may have, benign things within the breast, or patients who are at high risk for breast cancer, and so I monitor them very closely throughout, their lifespan. So with respect to cancer treatment, primarily patients will come to me, they've had a abnormality on a mammogram or an ultrasound, and then subsequently had a biopsy done of that abnormality, and it shows cancer. So they come to me for guidance as far as what the treatment plan is going to be for that cancer. And primarily, as I mentioned, I do the surgical aspect, but also as a fellowship trained breast surgical oncologist, I have a full understanding and scope of how, for instance, medical oncology plays a role in the management of breast cancer, as well as radiation oncology. So I have that conversation with the patients. We focus on the surgical aspect, but I also introduce, the roles in which radiation treatments and chemotherapy or medications play in their management of their breast cancer. And I essentially become their guide as they go through that journey of their treatment.
Well, you talked a bit just there about your journey, especially about being a fellowship participant as well, and the level of care that you can provide. Right. I wonder what that arc is from the time you decide, I want to be a doctor, and then you end up here in the position that you're doing.
Yeah, that's a great question. So I always knew when I was young I wanted to be a doctor. I mean, my family would tell you, someone always said 8, 9 years old she was going to be a doctor. So everybody knew I was going to be a doctor. So I actually went to undergrad at Rutgers University in New Jersey. That's where I was actually raised. So I didn't venture far for undergrad.
Yeah, New York East in New Jersey.
Well, you'll see I went through essentially the triangle, the tri-state. So I started off at Rutgers, did my undergrad degree there in biology. I actually spent a few years out of, after getting my degree, working for a cardiologist. I did some graduate level training. After that, within biomedical sciences.
Was that a crossroads thing? You were like,
I'm
going to be in the heart, or I'm going to be for oncology?
It was kind of the crossroads, kind of, figuring it out, kind of figuring out which direction you want to go. So then I went to medical school at Drexel University in Philadelphia. So again, not venturing far, just down the turnpike. Right. That's where I got my medical degree. And I actually did my surgical training, my general surgical training here at Brookdale Hospital.
All right.
And during that time, between my second and third year, I did a year of research at the Will Cornell Breast Center. And that really opened up my eyes to the multifactorial nature of managing breast cancer patients, the collaboration with other specialists, and really the relationship you establish with patients over time. And so I really like that part of it, because a lot with surgery is you see the patient, they need surgery, you do surgery, you see them maybe once or twice after surgery, and then you never see them again. With breast cancer, it's different. You really get to establish that relationship long term with the patient, as well as do surgical operations. So that really got my interest in pursuing breast surgical oncology. So after I finished my residency, I did 1 year of fellowship training specifically in breast surgical oncology at Bryn Mawr Hospital in, again, Pennsylvania, right outside of Philly. And now I'm back here in New York.
Yeah, it delivered you back to us in the forum, and you're doing so much work that we're thankful to have you a part of our community of care here at Brookdale, and certainly for New York and Brooklyn specifically as well.
Right. I mean, that was part of my motivation. Being that I trained here, I saw the need for quality services as it relates to breast cancer treatments.
Right.
And I grew an affinity towards the patient population here. So that was really my biggest motivation for coming back, because I really wanted to go somewhere where I can have an impact.
So let's talk about that impact. Can you talk about if there is a certain thing as a typical patient profile of the people that you work with here at Brookdale? Who are the patients that you see, and what can you tell us about them?
Well, the patients are actually kind of broad. I see young patients. I see patients in their 30s and 40s who are, high risk. They have a very significant family history of breast cancer. So, I counsel them about ways in which we can closely monitor them, and also some risk-reducing strategies. And also, unfortunately, I see a lot of young breast cancer patients. But then you have your middle-aged patients who, are in the throes of their life, working, have children that are school-aged, and, are diagnosed with breast cancer. And then I have, older patients. I take care of some nursing home patients who, develop breast cancer. So it's really a broad range of patients, which, is also a good thing for me, because, you don't really ever get bored. You're not seeing the same person over and over again. Everyone's breast cancer is different. Everyone's journey is different. Everyone's background and story, what they bring with them is different. And, that guides you on how to appropriately counsel patients.
When you spoke a bit ago about dealing with some of the younger patients and this idea of preventative care and getting people into routines, I wonder if you could clue us into some of those things for people who have not entered into care or may not have a breast cancer diagnosis yet, and hopefully will not, but just about preventative things and regular routine maintenance that they should be doing.
Right. So that's also a really great question, because there is some variability and screening, particularly with mammogram. So the U.S. Task Force recommends that women start their screening with mammography at the age of 50.
Oh, wow.
But I'm
Doesn't it seem late? Like 50,
yes. Yes, it's a point of contention.
And you go,
to say the least,
40 years with breast, and then you show up on your 50th birthday and get a mammogram?
No, so I'm part of the American Society of Breast Surgeons. Most oncologic entities all recommend starting with mammographic screening at the age of 40. That may drop down depending on your family history. So, I mentioned seeing younger patients who are high risk. If that patient's mother, let's say, were diagnosed with breast cancer at the age of 45, typically we recommend those patients start their screening with either mammography or breast MRI 10 years before their mother was diagnosed with breast cancer. So they would be starting at the age of 35 rather than 40. So that's what I talk about when I mentioned it's really targeted towards the patient and their particular story, their particular history.
Got it.
So those are some of the things that play a role. And also genetics. Genetics is something that's underutilized, particularly in our patient population. And that's something that, we, in conjunction with, medical oncologists and primary care providers, whether it be internists or our gynecologists, and really, offering that to patients and really, identifying patients who are at risk and who should really be counseled about undergoing genetic testing to see if they have a genetic abnormality. And if they do, there are ways in which we can reduce their risk of developing not only breast cancer, but ovarian cancer, colon cancer, the whole gamut.
When you look at the sort of popular culture and when we are confronted with breast cancer and caring for it, there, you point to the Angelina Jolies or the Christina Applegates where they did have the benefit of genetic testing, and people may think that it's something for rich and famous people off in Hollywood, but as we're sitting here in Brooklyn right now in the Brookdale community, how easy or what is the process for saying, what my grandmother may have or my mom is, how can I get tested for this gene to see if I have more of a prevalence for developing?
Right. So it's as simple as a blood test or even a saliva test.
Really?
Yes.
You could just get a plain old
You
swab.
can just spit into a cup.
Get out of town. I didn't know it. So there's...
Actually, that's the test I prefer to do in the office, so you don't have to worry about, whether a person has a good vein. Or,
There's no inertia to get over. All you have to do is be in the room and say, hey, doc.
Yeah, I see patients all the time. I review their history, and I say, based on your history, I think, you would benefit from genetic testing. We have the testing kits right there in the office, and we take care of it for them right then and there. There was a time where genetic testing was very expensive.
Like a prohibitively expensive.
Exactly.
Yeah.
But now with the evolution of, understanding genetics, we're able to do those tests at much less cost to the patient, and most of the time with no cost to the patient.
Phenomenal. So that's the news you can use portion.
Yes,
this
absolutely.
Is care that's available.
It's readily available.
Yeah, knowledge is power, right?
Yes.
You're arming yourself with this.
Absolutely.
So what other traditional ways? Can we talk about self-examination for a minute? I know that's key. Like, I lived in a house in college where it was a mixed house, and there was a little tag hanging in the bathroom, in the shower, and it was like, oh, that's what you do. So that's like, I know in theory how to do a breast self-exam from that tag, but I've got an expert here. Enlighten us again.
So I always encourage women to examine their breasts once a month. And it's really, and I tell them, it's really to familiarize yourself with how your breasts feel.
To know what you're working with on a regular day.
Exactly.
Yeah.
Patients are, well, I don't know what to feel for. I don't know what's normal, what's not normal. I say, don't worry about any of that. Just focus on what your breasts typically feel like. That way, if something were to change, you would be more inclined to detect it. And I'm a big proponent of patients being an advocate for themselves.
Absolutely.
So the more you're familiarized with your body, the more you feel, emboldened to, advocate for yourself. If you go to a doctor and say, hey, look, I feel something in this breast, it doesn't usually feel like that. The doctor may say, oh, well, I don't really feel anything, or it doesn't really feel like much. No, don't take that.
It's like, I know me.
No, right. That's not the end of it. If they don't want to take the next step and do the proper diagnostic workup, then you find someone who will. So you should examine your breasts upright and also laying down, making sure you examine the full breast, also up into the armpit area, because there are breast tissue that goes up there, as well as the lymph nodes.
Right.
So that's what I encourage patients to do. Yeah.
So that self-examination is one part, but I'd love if you could clue me into, aside from the genetic testing, which may actually be free and as easy as putting a little bit of saliva into a test tube, about the services that are offered at the One Brooklyn Health Breast Center.
Okay, so let's start with imaging. So that's a big part of screening for breast cancer. So we offer mammography here as well as breast ultrasound.
Okay.
So that's one part.
What's the difference between mammography and the ultrasound?
Good question. So a mammogram is essentially an X-ray of the breast.
That's the smush.
Yes, that's the smush where they squish your breast between two little plates and take, contort your body so that they can get, good pictures of the entire breast. So that is a good screening tool. It allows us to visualize the breast tissue. It allows us to see any masses in the breast. We also look for things called calcifications, which can be the earliest signs of breast cancer.
Yeah.
So that's a mammogram. Ultrasound uses sound waves. So if you had a child and they did an ultrasound of your belly, it's the same technology, except they examine the breast and create pictures from that. And that gives us an additional vantage point or view of the breast tissue. I never use the term one is better than the other. They both have their role to play as far as screening and diagnostics. Yeah.
So you've been screened, you've been gone through the diagnostics is a word.
Yeah.
But I'd love to talk about this moment that we're in now where so many people got thrown off of their routines. The last place they wanted to be was in the doctor's office, whether you're masked or whatever is happening, and keep it close and stay at home.
Yeah.
So how do we get people back into their regular routines now who may have fallen off, and you need to get back in there and get your imaging done?
Well, I think platforms like this are very helpful because it kind of triggers something in the person's mind. Because with COVID, we've all been thrown upside down, and so it's no wonder people are kind of not thinking about getting their mammogram, and not even realizing, oh my goodness, it's I did my last mammogram was in 2019, and we're almost at the end of 2021.
Yeah.
So I think platforms like this, when the primary care providers are seeing patients, to continue to encourage and remind patients, hey, I see your mammogram wasn't done. You need to get scheduled for it. So
yeah. Is there any tip? I know it helps me to just put something on the calendar where it's you got these Google calendars. My brain is in my pocket right now in the form of a mobile phone. And sometimes I just put things on the calendar and it tells me a week or a month ahead. I'm like, oh, do that kind of thing. Are there any tips that you've learned or could share with us about just staying on your routine?
Yeah, well, I'm all for a calendar and reminders. I mean, I set reminders all the time in my phone. We use an electronic medical record, which has a little tab where you can remind yourself. So I probably overutilize that tab because I'm always sending myself reminders because it's hard to keep track of everything when you're just going, through the throes of life. So that's what works for me, reminders. And keeping a calendar.
Well, keep that calendar. That's important. I wonder, as we look at the level of care that people get to experience now, and you spoke about how these genetic tests now have been brought down to earth with the advances. I wonder what other kind of advances you could share in the field of breast oncology specifically, because breast cancer is a brutal thing, and the treatments before were life-saving, but some of the treatments I know just from family members and people who came in previous generations were pretty brutal too. But now we've come a long way. I wonder if you could help to massage people into feeling better about the prospects we have now.
Yes. That's a really important question because it's true. I mean, you'll be hard-pressed to find someone who hasn't known someone with breast cancer. So their experience will not necessarily be your experience. So with respect to care and how we've advanced, from a surgical standpoint, there was a time where we removed all of the breast, the chest muscle, just leaving women very deformed and, disfigured. We've scaled that back. We know with lumpectomy and mastectomy, when we're talking about early stage breast cancer, that's either stage 0, 1, or 2. The outcomes are the same whether a patient has a mastectomy versus a lumpectomy. In general. There may be some caveats to that. So, lumpectomy is where we just remove the mass
Very localized.
Very localized treatment. I use techniques called oncoplastics, where we always keep in mind the contour of the breast when we're doing our excision. So the onco is making sure we get the cancer out in its entirety, because that's absolutely
That's
goal
the
number
reason.
one.
Yeah.
But goal number two is also maintaining the contour and shape of the breast, so women don't develop those disconfigurations within the breast tissue, because it's important for patients long term. Their quality of life. You want them to feel good about themselves, and not have a constant reminder of that part of their life. With respect to medical oncology, our treatments have become very much more targeted. We talk a lot with patients about the biology of their breast cancer. And so based on that biology, there are certain treatments that are more effective against that particular cancer versus others. So those are just kind of some tidbits about kind of the direction in which breast cancer has gone from a surgical standpoint, also from a medical oncology standpoint. It's becoming very much more individualized and targeted in what type of cancer we're dealing with.
Can I speak to you as a doctor and a woman of color working in a community that is representative and like coming in and feeling comfortable, and the level of comfort and care that you're able to provide, and the perspective that you may share with women of color as they come in and go on this journey? How important is that to connect with a doctor in a way that you can relate to them and know and just have a level of comfort and understanding when you approach care for your patients?
I think it's most important because, one, when a person hears they have cancer, naturally is fear and anxiety. And when they come into an office where they can relate to the person who is going to be counseling them and guiding them as to what is the best treatment options for them, it's so helpful when they don't have that added barrier of, being with someone who may not quite understand their particular perspective or their lived experiences. And, being in tune with, because there are times I talk with patients and I can, kind of sense certain things, from the conversation. And then I take the time to speak to those, underlying anxieties that they have, which, are rightfully so, because, everyone has their own experiences. So I think those are key things, because ultimately the patient has to be on board with their treatment. And if they're unsure or anxious, they're less likely to, follow through with the treatment. So I think that's really the importance of really having that added benefit of someone who, can relate to them in that way.
Speaking to that insecurity and that anxiousness that you might feel, like you said, when you get that diagnosis, it's easy to go to that fear place or that dark place. I wonder if you can share some advice or tips in the sort of holistic way of cutting off yourself from your diagnosis, because I just, again, from just familial experience and like having friends, when you get that diagnosis, it's easy for it to become your full-time job to be a cancer patient. But I wonder if you could talk about how important it is and maybe share some insights on being in care, staying in care, but also divorcing yourself from that moniker.
Right. So the conversations I have with patients, I often start by getting to know them. Asking them where they're from, where their family's from, you have children, just trying to kind of ease the anxiety within the conversation. And then when I'm talking about our treatments and our treatment options, I always want to put in the forefront of the patient's mind thinking about what do you want your life to look like 10 years from now? And I do that intentionally because I want them to have that mindset. I'm going to be here 10 years from now.
Right.
So I need to be thinking about what it is and what I want my life to look like 10 years from now. So I think that helps, because, the doctor you're talking to me about 10 years from now, she just told me I had cancer. Because when we detect breast cancer early, our treatments are, very, very good, and the outcomes are excellent.
Early detection is key.
Early detection is key. So that's how I, try to, formulate the conversation so that we can always keep that, as you mentioned, holistic approach. You're not just a breast cancer patient. You are you, whatever that is. And I always want you to keep that in mind when you're making your decisions, and also when you're thinking about, life beyond this, because this is just a footnote.
Yeah. So like project yourself in 10 years in the Bahamas
Right.
in that bikini,
Exactly.
enjoying your life. You're not
Exactly.
just here. It's
And I talk
crucial.
about, scar placement when we're doing surgery, and they're like, I just want the cancer out. No.
Yeah, I just want the cancer out too, but I want you to be happy when it's done. Yeah.
You like going to the beach, you like wearing certain things. Okay, so we need to make sure that, within reason, we can, fashion an incision so that, you're not constantly reminded
Yeah.
or feeling,
Can't do this. Can't
yeah,
wear
right,
that.
exactly. I can't wear this or I can't wear that because, I don't want people to see my scarf.
But that speaks to the level of care and foresight that you have to say, where would you like this scar? And I can imagine some people falling back and they're like, I don't care, girl, just get this cancer out of me kind of thing.
Or would you like a lift? Like, how do you feel about your breast? Because, again, going back to the oncoplastic surgical techniques, we can take out the cancer and give you a nice breast lift at the same time. And it's covered by insurance.
Amen, amen. Insurance got it right the one time. So
Right.
as we are wrapping up now, I just want to thank you for spending some time with us. But I'm thinking about that 8-year-old future Dr. Mays who knew she wanted to be a doctor. What advice would you have for any 8-year-old right now who is like, I want to be a doctor too? What would you say to that little girl?
If there's anything in life you want to do, you have to work at it. And the biggest thing, don't ever let anyone tell you what you can and cannot do.
I'm going to leave it there. Thank you, Dr. Mays, for joining us today. I'd like to thank you for your interest in the show and your desire to become involved and educated. We invite you to visit our website at zermed.com after the wwws and check out our tools and connect with us on social media. You can also give us a ring at 718-510-2103. Stay well and be safe. Bye now.